Welcome everyone to the Global Education Colloquium. It's great to see so many friendly faces here today for our April 21st presentation. We're very, very excited to have Dr. Kim McClellan here, who graduated from Drexel School of Education with her doctorate a couple years ago, and she'll be presenting some of her research. We're also very excited because this is a presentation we had hoped to offer last year, but when the pandemic hit, Kim was, of course, needed in other places in a greater capacity than where we needed her. So we're excited to have you back this year. And for those of you new to the Colloquium, we have about an hour. After I do a quick presentation, we'll turn it over to Dr. McClellan to get us started. So if you have questions or comments, please feel free to put those into the chat as we go, and we'll have time at the end to address them, as well as hopefully to open up mics and allow more people to talk and engage with our speaker today. So let me introduce you to Dr. Kimberly McClellan. She is an assistant clinical professor in the College of Nursing and Health Professions at Drexel University. Her primary clinical focus is driving the evolution and application of care models formulated to advance cultural and gender-specific care access and outcomes. Her research interests include African and gender-related cultural aspects of HIV primary care. She uses qualitative research to integrate translational concepts such as communities of practice, education, cultural humility, and health promotion to inform evidence-based care models in the US, with a particular focus on supporting immigrant communities. Dr. McClellan holds nurse practitioner board certification in both women's health and family practice. She has extensive experience in the clinical areas of women's health, family planning, and community health and HIV primary care. She maintains her active membership in the American Nurses Association, as well as the Pennsylvania Coalition of Nurse Practitioners. And she's a founding vice president of the board of the African Family Health Organization. Thank you so much for sharing your time and expertise today. We're really excited to hear your presentation, and I will turn it over to you. Thank you.
Great. Thank you so much, Dr. Kelly, and thank you for everyone who's joining us today, and I really appreciate your time. As I speak about just the love of my life, but the group that I am honored to be part of and get to work with every day. So as Dr. Kelly had mentioned, this discussion is about some research that I had the opportunity to do as part of my EDD dissertation. And it is about the group Promise Keepers, which is a group-mediated education by and for, very important to say, by and for African-born women that are seeking HIV care in Philadelphia. This is, my hope is to talk a lot about the findings of this particular study, but before we dive into that, I felt I should define really what the community of practice is, because I will admit that although it seemed like the community of practice was the correct title to give this group, that's something that my research really had to show. And more importantly, something that the particular group of Promise Keepers needed to inform me on whether they felt the fit of this particular group. So as we define, and as is defined by the literature, a community practice is a group of people who share a concern, a set of problems, or passion about a topic, and who deepen their knowledge and expertise in this area by interaction on an ongoing basis. And a little bit of a spoiler alert at the end when we talk about the conclusions, it was indeed shown and member checked through the Promise Keepers that our group really was defined as a community of practice. Also very important to start with my positionality in this work is that I do really, believe, and the literature supports, that a community of practice should and does reject the reduction of knowledge as an object. This very much is a living and breathing entity. constantly evolving. And we'll talk a little bit about the idea of cultural humility as well, is that this is an ongoing process, living, breathing, and being contributed continuously and constantly through the members. My stance and my positionality started and was later shown to be the role of a participant observer. And I feel very honored always that Promise Keepers believe me to be a true participant and active participant in their community of practice. Really needed to be perceived as a member of this group, of course. And again, spoiler alert, I did find out, and the group did show that I was definitely part of this community of practice. Seen as an equal member, all members giving a different skill set, but equally important area of expertise. The Promise Keepers, and we'll talk a little more about the fact that that was the name that they gave themselves, positioned me in this way to be and act as people like us. And that'll come out as some of the qualitative themes that came out of the research. Practicing ongoing and engaged reflection and represented through analysis and the inclusion of the voices. Important to also position the members of Promise Keepers here and position this research is to be truly participatory and community-based. All of these findings really needed to be, and all of the later implications needed to be set, as the voices, as the lived experiences of this particular group. Also, the study design needed to be effective in the process in regards to ensuring this continuous, constant member checking, member inclusion that was racially, culturally aware, and also fitting well in with the mantra of all the voices, that all voices as a community practice needed to be equal, represented, and not one with privilege over another. I also would be remiss that if I did not discuss my acknowledgement of Dr. Christy Kelly, Dr. Christine Lewis Grant, and Dr. Loretta Jamot, who really were my committee members and amazing women and helped me immensely with this work. Okay, so the statement of the problem. Really the reason that this work needed to be done, driven to be done. And I would also say that every member, even though they're not here with us today, every member of Promise Keepers really has ownership and needed to have ownership in this particular body of research. So the problem really is that there's a disconnect, and we start there in that, as this group of women, born on the continent of Africa, but now finding themselves here in the US, HIV positive and seeking care, is that there really is a disconnect in many ways. One way is that, African-born often practices, as voiced by the women, of not only HIV care, but also care as a whole, tends to favor more community care, a more community flavored approach, where in the US, our model is not necessarily this way. So there's this conflict. Conflict in the US model that is more prevention driven than illness driven, more individualized than communal. Also, in the way our funded care happens in the US care model, it often funds and has more plentiful for access to care and arenas to care for populations of prevalence, meaning HIV specific care is often funded and driven from our funding entities to have more funding programs for whoever happens to be the population that is more affected by HIV in that given period of time in a data set. So, for example, if the CDC says that in Philadelphia, the greatest number of individuals living with HIV are men who have sex with men or women who utilized opioids, that will be the segment of that particular funding stream or that particular funding year through the government that gets more care. and more programs that center on their care will receive more funding. And although we know that many individuals are living here in the US and in Philadelphia area specifically, that may have countries of origin from the continent of Africa, they are not generally the largest or reflected in the data as the largest group affected by HIV. So their funding streams are often much smaller and the access to care is reduced. There also is a reduced or perceived risk of HIV treatment and disclosure that there's a benefit to that. And there's a disconnect here with this particular group as well. Not in any malicious way, but we as HIV providers are often counseled, educated that if an individual discloses their HIV status to their support systems, to their family, to their friends, that they will receive a more benefit for that treatment, that they will be able to reconcile more support. And this is also a disconnect. And the study that Promise Keepers and I did together did validate this, that the perceived risk of disclosing to your community was much greater than the perceived risk of seeking treatment for your disease. So if we put all this together, and you can see the cartoon here with the scale, is if you see the barriers to care, and if that is fear of disclosure of your HIV and possibly losing your support systems because of that, disbelief that the care model or that the care that you may seek for HIV is going to be helpful to you, and that isolation will end up tipping the scale further to stay away from treatment. And, perhaps could we utilize, and this was the basis of the study, is could we utilize this existing community of practice with the idea framed in the health belief model to kind of tip that scale more towards wellness and treatment. The significance of this study and the purpose really was derived from the need to redress the injustice of health disparity. So everything that we just spoke about, as far as reduced access to care, a disconnect with the health model and the wellness model of the US and those from the African diaspora. Can we redress this injustice? Access to care should also not be rationed. This whole purpose that we should not ration care to just populations which acclimate to the culture of the majority. So although funding streams may do that, and that's a governmental decision, we as clinicians and practitioners and educators, can we tip that scale for ourselves and say that care should not be rationed just to the culture of the majority? This leads us to the purpose of this study was to examine, again, this role of this community of practice that we believed and were later found that it truly was a community of practice among African-born HIV-positive women that were seeking care. Can we examine this role and how it really did it affect that scale? Preceding qualitative research did give evidence, starting out, that this population would value community involvement in the issues of health and wellness. However, there was really little understood regarding the role of a community practice and how it could serve here in this arena. So the questions that were posed at the beginning of this research: how do African-born HIV-positive women describe their lived experiences as members of this community of practice? If we take the framework of the health belief model, how do these same said women describe their perceived risk and perceived benefit of participation? Participation as members of the community of practice and also in their own external community. How do individual members of this practice define their role within the group? Their role as members, their role with other members, and their role in their own external community. And this internal and external community will make sense in just a minute. And I apologize for the fire alarm going off in my town. It always happens at the best times. And then finally, what constructs of the community of practice do HIV-positive African-born members describes as contributory to their own perceived wellness? The conceptual framework, and what ended up being also the literary review of this work, looked really at three facets of this, with the central idea that HIV-positive African-born women do tend to access HIV care at suboptimal levels in the US, and what barriers that exist that diminish that access to care. And if we looked at the structure of the care, HIV care in the US, variances healthcare that were cultural and variances in healthcare that were genderized. And we'd have to look also at the structure of care participants, their institutions, their perceptions. Culturally, what is the wellness and disease perspective and the emphasis of community care? And then by gender, how do women in this group and women, in the literature position themselves often as caretakers and as care recipients? And then if the central theme here is that these women are possibly at risk for accessing suboptimal levels of care, how could the intersection of this community practice, this operationalized use, maybe provide a surrogate support and a way to navigate these existing barriers? The methodology and the design of this research was qualitative, absolutely, constructivist, and phenomenological in its basis. The choice there was we wanted to describe, analyze, and interpret, but acknowledge that reality is socially constructed and that understanding and investigating this lived experience, this phenomena in the voices and in the lived experiences and the stories of promise keepers. The participants of this particular study, it was a purposeful, homogeneous sampling from an existing community of practice. Again, have to stress, we did not call ourselves a community practice at this time. Many of the women that are represented in this study, we were together as a group for 10, 15 plus years. Didn't always know why it worked, but just knew it worked. It was very organic. It was, as we said, very purposeful, and just was working. And we needed to take a look, not just myself, we needed to take a look at really why this was working. And then we can go on to more implications in a bit. There were 7 African-born women, representative of 5 diverse countries on the continent of Africa. The practice site was at times held at Drexel's College of Nursing and Health Professions building, Parkway Wellness over on the Center City campus. But really important to acknowledge more than anything that this was really a space, not a place. It did not have to be a geographic brick and mortar place. And that will come out later in the voices of promise keepers. So we sometimes met in members' homes, which was very normal for us. Telephones, Zoom meetings, anything that we could do to speak and talk when really the group felt that they needed to do that. There were assumptions and limitations as well. So assumption would be that the members would create this safe space for exchange and gained and situated insight. That was the assumption. That's what we felt was always happening, and we assumed it would continue. Limitations could be that the findings may not apply to all women living with HIV or even all African-born women living with HIV. An HIV provider, at that time, that was my position, ability to assume the role as a legitimate peripheral participant. Now that's very community of practice speak for all educators out there that you know that already. But the idea, again, that I was inserting myself in the group was welcoming me in as an equal partner and member of Promise Keepers. So let's get to the really good stuff, right? So teased all that up. Let's talk about findings and more importantly, the voices of the members of Promise Keepers. And I'll be able to tell you a little more about why that title was actually chosen by the group. So the findings of this study were grounded and were emerged through the voice lived experiences of this particular community of practice. One of the most profound findings, which I'll elaborate a bit more in the voices of Promise Keepers, was really this restoration of self. The idea, and then assumed through this and the vehicle to get to this restoration of self, there were through coding, through analysis, through constant comparative methods of these themes and codes, the idea that internal perception of self, external perception of self, and community, right? And again, through this process, it was really found through the Promise Keepers that the most profound finding was the restoration of self. And each of these particular themes had codes that went under them, such as, example, the essence of self-worth, which really speaks to that health belief model and that self-efficacy. External perception of self. Difference here is that internally is much more about how do I feel about myself? External is how do I feel about myself in terms of this group? How do I feel that others in my community, my African community, see me? And then community, and we'll get back more and more to this people like us, this idea of education, self-worth, and equality. So we're going to ground this section really, again, in the voices of the Promise Keepers, because I just could never do a better job than they could of speaking in their voices of where this internal perception of self came from. So when asked questions, and I will go back to, and I'm realizing I never mentioned, and I should mention kind of where these questions and these codes and these themes actually came from. So with my work, through interviews, through individual interviews, which is how this study first started, it became very apparent through even just the first individual interviews, while they were incredibly rich with these 7 women. Very quickly, I realized that the natural progression of this group and the natural life of this group and our conversations really were held, quite honestly, in the group itself. So while all interviews were done individually, there was added on, I even went back for any of those that are in the midst of it, it's okay if you need to go back to IRB again, because we did. We went back to IRB and said the natural flavor of this group, the voices really need to be also seen in the group setting. So I went back later and requested to be able to add a group interview, a group focus group to this study, and that was done. So you'll see in these voices here and in these codes and quotations that you'll see some were attributed through the group and the focus group, and some were through the individual interviews as well. So in this question, and sometimes we never got past this first question, is simply tell me the story of the group. And I even ended up answering that myself as an equal participant. But each group, each individual and in the group setting was asked, what is the story of the group? And again, sometimes we would never go past that. Very culturally voiced as appropriate, as competent to this group was just storytelling, using touchstones to go back and find themselves, find their recognition in the group within their stories. So if I asked a question, what about the group? What happened when you were alone before the group happened and you found out you were HIV? How did you feel when we added the community of practice, right? So some quotes directly from the voices of Promise Keepers was, when I found out I was HIV positive, or I thought about being HIV positive and I was without the community or the sisterhood of Promise Keepers, I would feel like I needed to hide myself. I would feel like I'm nobody. I have no hope. Everyone is better than me. They are better than me. I feel damned. And when the question turned in the conversation or the story touchstone came to what did our group, what did our promise keepers do in this? What was the intervention? What was the intersection of this? And instead of being alone and feeling like I needed to hide, it gave me myself back. My sisters opened me up. My sisters made me feel like I'm somebody. I have myself. It gave me hope, and hope is life. Realized with my group, I'm human like others. And then rather than feeling damned, I felt like God made me strong. I'm not damned because I'm HIV positive. Instead, God is making me strong. There's a purpose to this. And what is the significance or the voice significance from the group because of these particular insertions or feelings with the community of practice? So again, the most profound finding and agreed upon with the members of Promise Keepers is that the group within their own internal perceptions, how do I now feel about myself? What is in my core entity as an HIV positive African born woman is the group is now, I've restored myself. I have a sense of hope. And if I have a sense of hope and hope is life, then I have life, then I have wellness. And if I feel like I have myself and I'm empowered because of the promises, my sisters, and that's where Promise Keepers come from, is we're keeping the promise to be this sisterhood, to be supportive of each other, to give each other ourselves back. We are not just an African-born woman living with HIV, feeling damned, feeling like there's no hope. I now have self-efficacy. I now feel not only do I have wellness, but I have the self-efficacy to know that I can act on this, that I can make myself well. And with the health belief model that is all about perception of wellness and perception of illness and perception of barriers, and that's the reality in this constructivist vision, then if I feel like I can do it, I probably can. And if I feel like I can't, I probably won't. All of these quotes were absolutely the voices of Promise Keepers. So bringing those voices in, and these are all pseudonyms, by the way, and it was very interesting. The group all named themselves. So the names were very interesting, and they actually gave me reasons why they chose them. So Diamond, when asked, what is the story of the group? Her quote, her theme was, my story for the group would be titled, How I Found Myself, How I Found My Courage and My Hope. Amy went on to say that there is nothing as killing or painful like hiding. So if you feel like you need to hide yourself not because of what others make you feel, but because of how you feel because of this HIV diagnosis, that is the most painful. Hiding something that you can't discuss with anyone. Now moving on to the theme of external perception of self. And again, as a reminder, the difference here is we're still speaking about perception of oneself, the individual group member's perception, but internal, of course, is how HIV makes me feel about myself. External is how do I feel around others from my community, my external community, my African community. But how do I think they recognize me as an HIV positive woman? So when alone, the members of Promise Keepers and in the group, focus group, they said that they felt like they would be abandoned, that others are judging them, other members from their external community are judging them, feeling that they're different. It's also important here to mention that the feeling was being derived from external members of their African community without disclosure. these women in Promise Keepers only disclose their status to this sisterhood, to this community of practice. So going back to the idea that this was a surrogate support system, and then positioning that surrogate support system in the US care model that drives us so often as clinicians to have individuals disclose so they get extra support. Again, the disconnect is this particular group did not feel like they could disclose to their normal support systems. So they had to create the surrogate support system to glean the same benefit. So if alone, without their community, they felt abandoned, judged, or different, the operationalizing of this community of practice, this sisterhood, in turn made them feel that they had people who put their hands around them, that they weren't feeling judged. You know, we don't point out people, we don't judge. A direct quote was, "We're all wearing the same shoes. We're all sisters and mothers." And when we say we're not all wearing the same shoes, that actually directly came from Pauline, who will be brought out to you in a couple minutes. But the idea is that if you're wearing the same shoes as me, if you're also an African-born woman, if you are also HIV positive, if you understand what disclosure to our external community is going to do, then I'm safe with you. You're not going to disclose my issues because we're sharing the same shoes, we're in the same boat. Okay. The significance of this is Promise Keepers believed that it restored safety. It restored this sense of sisterhood. You know, you could be your real self. We'll talk about that when we talk about community, but I could be my real self with my sisters because they truly understood me. I don't have to put on this fake person, this facade of who I am. And you can really gain understanding and that support that you need. Some direct quotes from members of the Promise Keepers. Emily said, you know, we're always together. No one else knows why we're friends, and that's good. And that directly comes and speaks to a really important part of this, is that this group is a space, not a place. Meaning that many members of Promise Keepers will see each other on the street, will see each other at a community event, at a church, at a mosque, and they'll pool together. And no one in the external African community really knows why they're such good friends, and they don't have to. And it's never really brought up as a red flag, because none of this group has disclosed to anyone else. So they could find themselves in a sea of community members and still be able to be themselves in this small group in a bigger group. And I think that they seek each other out, they give support even in a larger external scheme. Also, Diamond mentioned that we all had mothers in the group. Not only did this group continually express the fact that they felt they were mothers and sisters and daughters to each other, very matriarchal in its makeup, very, very feministic in its makeup, of course. But even just the fact that they had mothers in the group, and they would bring their own children into the group. And many, with the exception of one of the 7, all members of Promise Keepers have actually shared pregnancies with each other, bringing their babies to the group, being supportive of each other. And I should say that that was very significant to them. Meaning that, of course, you know, their family members, their external community knew they had pregnancies, knew they had a child. What they did not know is that they did this in the face of HIV. So that would be something that the voices of the Promise Keepers would say that would be very judged. You know, there's a belief, first of all, in, you know, and this is well documented in the literature, that many individuals that are of a country of origin of Africa or the African diaspora sometimes questions whether you can even have a pregnancy. Not that you shouldn't, not that it's not right to do, not that it's a moral judgment, but your body just doesn't allow you to become pregnant if you have HIV. So many of the women in Promise Keepers not only could not share their HIV positivity with their family members, they had to do things like hide the fact that they weren't breastfeeding, because that could be disclosure. They had to hide, sometimes from their partners that they were positive, or their families or their friends, because they would be shunned, right? So they could come together in this Promise Keepers group and have a sisterhood and have a safety net and have a support. That's an important point, and we'll speak more about that when we talk about community. So specifically to the community trend here of finding, and a very important quote will come out of this, that people like us, is that when the group was asked, how did you feel when you were alone with this sense of community? So quotes such as, we're afraid to tell who we really are. I sit alone. This idea of taboo kills, being alone kills, right? So it's well documented, even with literature outside of this study, that in many related studies, there's this belief that, the stress of having HIV will kill you before the actual disease. And it's not just the stress of having the disease, but the stress of losing your community, of disclosing your community. What's very well documented and not a surprise at all, from the beginning to the end of the study, but not quite as profound as the loss of self in the study, is that this study documented what countless studies have, is that there is this profound fear of losing your external African community if you disclose. And that was resoundingly validated by this study and by the voices of Promise Keepers. So again, this idea that seeking care, which could then make you disclose to your external community and lose your community, is going to kill you before, and in the whole positioning of the health belief model would be a reason to stay away from care. So that perceived benefit of getting care and that perceived deficit of getting care, the scale is shifted, and it's much better to stay away from care and die from the disease itself, because either way, this taboo is going to kill you. When we add in the implementation of community of practice of the Promise Keepers, telling your story, and again, this was one of the first questions, and usually the only question often, is telling your story to help other people, right? Even in the face of being afraid of that, because you had this sisterhood that put their arms around you. Pauline reflected back on some beautiful, and I should digress for a minute and say that Pauline is often seen as the matriarch of the group, of the elder of the group. And she, as many members of Promise Keepers, tends to speak in stories and would use quotes and proverbs, African proverbs that were just beautiful, like to go far, you go together, right? The whole idea of people like us, that we're all equal and important. That was very integral to the group and the voices, that we're all equal, we're all important. Very community of practice, right? And we need to wake up and tell the truth, right? And that goes to telling your story and helping other people. This sense of advocacy, the sense of being privileged in that you're in this group and now we want to help others. Even if it could hurt us, we have strength in each other and we can stand up to that. So the significance of this, and was later confirmed by the members of Promise Keepers, is this restoration of community. Maybe we can't go back to our external African community that means so much to us and be our true selves. We have to be these fake, non-HIV positive individuals with them. But we did restore our own community here. So we were losing that, but we regained it here. And then this sense of belonging, this sense of equality, again, gaining this safe space, not a place, but a space of safety. And then moving past just safety to empowerment. And I have to say that working for 10 to 15 years with the members of Promise Keepers, I always marveled at their strength and their resolve. But I was surprised by this, that their need, or just their that sense of hope that allowed them to go to the next step, and really empower themselves and the group to go out and help others and to put away their own fears. Truly brave. So some of these quotes that are so rich. So Emily again said, we know we're all equal in the group, and that helps us to be sisters, to know we are one, to know that no one is above another. Again, some of these not some, but all of the members of Promise Keepers had very similar quotes, which is what we led, in to say, absolutely, this is a community of practice. That's the definition in and of itself. And then Pauline again, this Pauline, this magnificent matriarch of the group, is that we're all wearing the same shoes, and if you wear the same shoes, then you know where it pinches. So that brings us to another really marvelous finding, I feel, that Promise Keepers validated, is that this people like us, right? And it also came back to show and be confirmed by the group is my positionality here, is that I'm going to feel safe with you. The question always was, can I position myself as the researcher, and are further implications to this for other disease processes, other actions of community of practice with clinicians, is can I really position myself to be equal? I'm not an African-born woman. I am not HIV positive. But what was recognized by the group is that that's not really the most important thing. Is what's really the most important thing, and what is defined by the group in the voices of the members, is, are you people like us? That doesn't have to be someone from Africa. That doesn't have to be someone who's HIV positive. What it has to be in the voices of Promise Keepers is someone who understands the mission. And that goes back to the community of practice too, right? So if our mission is to make sure that we were all safe, that we all maintain this sisterhood, and that we all know what the dangers could be, then we know where the shoe pinches. We all care about the same things. And whether you are African-born or you are HIV positive, the fact that those of us who were not fitting into that particular distinction, but we came and we understood the mission, and we understood the risk of tilting that scale away from the mission, then we became people like us. So the conclusions, and just to revert back to what the purpose of this study was to examine the role of a community practice among African-born HIV positive women, specifically in Philadelphia. This had to be grounded in the stories of Promise Keepers. Again, the most profound finding was this loss of real self. Where can I be my real self? Right? And if I can be my real self, I can restore that, and I can find this self-efficacy to be well. The members of Promise Keepers equated this restoration with the restoration of hope. And if hope restores that definition of wellness and self-efficacy and self-worth, it is this continuum through this mediated safe space, and it tips the scale to achieve that wellness, that being greater than the perceived risk of the disease, going back to that Rosenstock's health leaf model and into that cognitive practice of self-efficacy, is that as long as I am there with people like us, I can be well, I can have hope, and one equals the other. Some implications for this is that first of all grounded in the stories of promise keepers, is we could have implications for practice, for teaching, and for research. And this, again, was all agreed upon by the group. So some implications for practice could be that we could enhance wellness and self-efficacy through the creation of these safe spaces. And perhaps we could explore applicability with other practices, other groups, other disease treatment states. I don't believe, and the voices of promise keepers have confirmed this as well, is that this is a phenomena that is isolated in just HIV or isolated just in being a member of the African community. Implications for teaching could be to impress upon the next generation of practitioners, whether you be a medical practitioner, clinical practitioner, an educational practitioner, the benefit of really true participatory care. This work would never have happened if there wasn't truly participatory, and based in this community of practice, this equality. Right? I will never be an expert in being an African-born HIV-positive woman, right? But we all come to the table with different but equally valued bodies of work. And then realizing that through this, we need to tailor our thoughts of practitioners as really, how do the communities we work with define wellness? We have clinical markers, we have standards of practice, whether it be educational, research, or clinical, but how does the group that I'm working with and working next to define their wellness? And then enhancing the practice of cultural humility. And I warned you that we talk a little bit about that, right? So we need to move past cultural competence. There is, in my opinion, and the opinion of promise keepers, there is no such thing. You'll never be truly competent. Culture is evolving. It is a lived piece of work, like this group. So constantly learning, constantly speaking to each other, constantly listening. Stop talking and listen. I'm going to do that myself in a minute when I give you guys a couple minutes to ask some questions. And then implications for research. This was a novel adaptation of the health belief model. The health belief model itself, has been, it's a rather, historical, often used in the public health space model for practice, for theory. But what I could not find anywhere in the literature was actually using this, added to the social cognitive idea of self-efficacy in the HIV arena, and certainly in the HIV arena with women living with HIV from the continent of Africa. So this is a novel adaptation of that. And then because it was truly based in participatory peripheral practice, anytime you get a chance to enhance the uptake of implementation science, right? So the idea that we do this evidence-based research and don't sit it on a shelf, actually go in and practice it. And that could be an implication for both research and practice. So in summary, study-wise, just in and of itself, there was preceding literature that talked about HIV stigma, the loss of external community, kind of that loss of, if you disclose, you lose your support systems externally. What this body of research and what the voices of the promise keepers really gave was this profound thought that it wasn't just that I was afraid of losing my community. I really was afraid of losing and never regaining myself. And if I lose myself and I lose my hope, then there's really no reason to think that I have the self-efficacy to ever be well. And that was resonant, continually checked, and really felt by the group as the most important finding. Members of this study also noted that the following path of education and creation of the state space by this community practice was an integral part of this path to hope, wellness, and self-restoration. And as a direct quote by Diamond is, if I have myself, I have hope. Hope is life. And the way to hope is education. And this continuum of clinical education, support, and sisterhood. And that leads me to just the title of Promise Keepers is, again, and what repeatedly was told in this story. And I know that these wonderful women are going to write a book someday. I hope they ask me to come help them do it, but they wouldn't need my help. But the idea of promise keepers, that they are the promise keepers. They are keeping their sister's promise for safety, for a safe space, and a way always back to themselves. And if they're the promise keepers, then their stories are the way makers. And it is these stories that they are passing on to each other, that they are now doing external community advocacy work. And the stories themselves, as they tell their stories, as they grow their story, will give hope to a new generation, an existing generation that otherwise would be hiding and isolating and feeling really no power back to them real selves. So thank you. I would take any questions and any discussion.
Thank you so much. I mean, I think there's no comments in the chat or questions, and usually we have them. So I'm just taking that as we're all riveted to hearing your framework and how you are, honoring the stories of the women that you have known all these years. And I can hear their voices here. I feel that they, that they're just in the audience as much as I'm in the audience. So thank you for sharing and taking the time out of your day to come and present. So we've got about 10 minutes for people to ask questions, comment, reflect back. You can put your questions in the chat, or if you'd like to raise your hand or open your mic, we'll keep an eye on the participant list so that everyone gets an opportunity to participate. A question from Ariel.
Awesome presentation, Professor McClellan. I like our other narrator has said, I am just absolutely enthralled with this information, and something that you said that stood out to me, that this is not an isolated phenomenon, that this strategy can be used in other approaches to other diseases. And I'm wondering if you have any advice as somebody who has successfully created this safe space for people to come and seek help and have this perception of wellness for themselves, how other practitioners could possibly get started or sort of implement this in other areas of healthcare.
That's a great question, Ariel. Thank you. Yeah, I think it just, I think that what is always resonant to me, and what I think about when I harbor back to the beginning of Promise Keepers, is that it really was just listening. And I don't know if I had that on my previous slide when I talk about implications for teaching and practice, but I think just teaching us all to, as clinicians, as practitioners, to stop and listen, and to give a lot of credence. We talk so much, and I don't know that we always hear while we're talking what communities that we're working with and working in are saying to us. So if you listen to what groups are saying that they need, and then you start those conversations, and then you have yourself, your mission as a practitioner, as a student, into what avenues of care you would like to get into. I think often it's going to sound like a trite answer, but it's going to reveal itself. And I think that when you stop, you listen, and you examine critically what isn't happening for groups. So we have lots of clinical standards. We have lots of clinical formularies that say, if I have this type of patient in this type of community, I'm going to institute this, and this intervention. But is the institution of those interventions, what the community is telling you if you stop and listen that they want. Does every diabetic equate a standard blood sugar reading as their definition of wellness? We probably do as clinicians, but do they? And so going back to Promise Keepers, you could go into any HIV practice, even those that are very community focused, and say to the clinicians, how do you define wellness? They're going to give you a bunch of clinical markers. That was the furthest thing from the members of the community of practice that I work with on how they define wellness. They say, I take my medicines. I know my blood work is good. That's not what's making me well. I have to do it, but it's really that I don't want to feel isolated, that I want to have hope, that I feel like it's important for me to do these things, So that would be my answer to you, Ariel, is stop, listen. And if you find that there is a disconnect between clinical markers of wellness and the way the community you work with is defining wellness, then ask them and listen to their answer on how you can implement change for that to get to their path.
Thank you so much.
Sure.
I have a process question
Sure.
on how you came up with that beautiful diagram. Like, how many different iterations did you go through? That's in the top right hand of all your slides that you introduced about the community of practice and all the inputs.
Oh, I just want to be sure I'm answering the right one. Let me see. This one?
Yes.
Okay. So I will admit I am not good at this kind of stuff, and I don't know if I should say this or not.
I'm
but
not sure I believe you right now. So
no. I love listening to people, and I actually loved coding. If anyone is just in love with qualitative research and participatory community research, I can tell you that I love it and just dive into it. And I love coding. I love theming. I love going back and talking to folks about my ideas and what are their ideas. So the words that are on this screen, I don't mind saying, yes, I did this. The idea behind this, just kind of became flow. So when you're coding and when you're theming, and you're pulling out this, it became apparent after many days, that this internal perception, external perception, and community were really the vehicle through the community of practice to this restoration of self. Now I just said, Dr. Kelly will confirm that was months and months, right, of reading, working, and working through this. But the diagram kind of just organically came. Now, the person who actually put this together for me was my husband, who was really good at PowerPoint. That was not me. I don't want to take credit for that. But the idea of the flow, and if you do have experience coding and theming, or you want to get experience, you will find that there is a way to, kind of visualize the flow in your brain as you work through these.
Thank you.
You're welcome. I hope I answered your question.
I have one more question, Dr.
Yeah.
McClellan. How did you find the 7 women that were a part of the COP when there was initially, this fear of disclosure? How did you get them to disclose?
Yeah, so that's a great question. Also, Ariel, thank you. So actually, the members of this community of practice, the reason that they came together, and they didn't all come together at once, and that is a great question about really the elements of a community of practice. So I loosely defined a community of practice, but the other components that need to often be there is, how do you gain members And how do you have new members and old members interact, right? So the idea is whether you're new or old, you know, again, whoever you are, you need to be equal. So these members of this group, actually, there were initial people that came together, and then they added new members along the line. And anytime we add a new member to the group, it is always a period of stress, right? So to quickly answer your question, what was occurring, and this was 20 odd years ago, is that, you know, we just knew, the particular clinical group that I was working with at the time knew that we had this occurrence where we had this influx of women from the continent of Africa coming in needing care. And what was very apparent is that, you know, they had this hesitancy, and I'm going to use their own voices, of course, is that, you know, someone would come in and say, you know, Kim, I'll come in to see you, but you have to promise me that when I come into the clinic, I'm never going to run into someone I know from the community that I come from. Because if they see me coming here and they know that I have HIV, then if I run into them, they're going to tell everyone, and I'm going to disclose, and inadvertently, I'm going to lose my whole support system. So, you know, realizing that, you know, one, I had one person, then I had 10 people, then I had 20 people, knowing that we really needed to kind of try and get a way to let folks feel safe. The other thing that happened is, you know, that I was working at the time with another member of the care community who happened to be not HIV positive, but she was from Africa. And we worked together to try to just see, can we safely bring some of the members of this community together, and will they create a safe space? Excuse me. So of course, we never brought 20 people together all at once, but what we would do ahead of time is ask one member by themselves and the other member by themselves, are you willing to meet with another HIV positive woman from your community? Do you have a safe feeling about meeting with them, talking to them, to see if you could partner up to become a support for each other? And that just ended up working. Of course, it was a risk. It was a risk for them. It was a risk for us. But again, going back to the health belief model, the perceived benefit, even to them at that time, was greater than the perceived risk, because again, they were wearing the same shoes. They knew each other's issues. And two people, one person partnered up, became two partnerships coming together as four. And then almost just like the cell develops, just, you know, keep coming on and on until finally you had this group of many, many people who all felt comfortable in the same room. And this harkens back to my first story, is that we never knew that this community of practice was what we were doing. We just knew that it worked. And we knew that women said that they felt safer when they could be a community by themselves, and not isolated, and feeling, you know, that they really had no one to talk to. And that still today is how new members join.
Yeah, that's great, because a lot of the nursing interventions that we discuss has a lot to do with building people's social networks, but then it's like, well, how do you even do that?
Mm-hmm.
And I think that you really did an outstanding job of doing that. So thank you for the inspiration.
Oh, thank you.
Thank you for your time. Thank you for this educational thing. Thank you so much. Really appreciate it.
Thank you very much for your interest. Thank you.
I want to just acknowledge it's 5 minutes past the hour. I know, Kim, you have other commitments this afternoon. I have 100 questions and I already read your dissertation and seen you present. I know other people could talk for quite a while as well, but I hope that people can reach out to you with further questions, set up some time to chat more about how you did your study design, what you're doing with this now that you're done, and where your next research projects are going. It's really, really important, the work that you are contributing to the diverse fields, but I think also the work that you're doing as a practitioner. So thank you again for sharing your time and expertise today.
Yes, thank you. And anyone who would like to reach out to me, as you can tell already, I love to talk about this. So please reach out. You can always find me, and my email is ksd23@Drexel. So happy to speak with anyone.
Thank you so much. And thank you all of you for attending today and participating.